Now, of course, adherence to ART is a central challenge for HIV-infected adolescents and their families. As we all know, ART transforms HIV from a terminal illness into a chronic disease, but central to this transformation is adherence. And of course, suboptimal ART adherence leads to opportunistic infections, more severe disease, and to viral resistance to some or all ART. And as Jim Young Kim said almost 10 years ago already, adherence support rather than regimen potency may be the single most critical determinant of long-term success in HIV treatment. Unfortunately, suboptimal adherence to ART is common. Systematic reviews of pediatric ART adherence in both resource-rich and resource-limited settings reveal high rates of non-adherence. And the estimates of adherence among children in sub-Saharan Africa, where 90% of our HIV-infected children and adolescents live, suggest that 60 to 80% maintain good adherence. But there's evidence that adherence declines as children enter adolescence and young adulthood. So what does this challenge really look like? For those of us who work in clinics with children and adolescents, we hear the stories of the burden of taking these medicines every day. And we see how the challenges of adolescence all come together to create many threats to ART adherence. I thought it might be helpful for you to hear about some of these challenges in Peter's own words. I'm going to read Peter's story from one of a set of narrative-based films that we use in individual and group counseling for HIV-infected adolescents and their caregivers in Western Kenya. We have a video of this, but Peter tells his story in Swahili and it gets a little bit long, so I thought I would just read it for you for clarity. But I do encourage you to watch one of our videos if you're interested. We actually have them with other educational-based resources on tablets that are by the poster number 47 presentation. So Peter is 13. His father died from HIV 1 year ago, and he's struggled to take his medicines for a number of reasons over the past few years. These are his words. I was so bad with my medicines. I just didn't remember to take them. I love soccer, and it's hard to remember to take medicines when you are busy playing soccer every day like I am. I wasn't trying to skip the medicines, I just forgot. I didn't know why I was taking these medicines. I felt strong. Then I was missing too many. I became sick and I had to go to the hospital. That's when I learned I had HIV. They were saying that I was sick because I didn't take the medicines, and so HIV was getting strong in my body and my body was getting weak. When I was released from the hospital, I just wanted to say, that never happened. I don't have the disease. I thought HIV was only something that came to bad people. I was feeling better and I thought it was some mistake. I think I was in shock. I wasn't listening. I didn't believe anything like this could happen to me. I didn't take the medicines again. I started to get sick again and I wasn't playing soccer much, and the other kids noticed I was too weak to play. They started talking about me. They spread rumors about me, saying that I had that disease. I didn't like the medicines, but I started hating being sick. There was someone at the clinic who helped me know about the medicines, a nurse, and she introduced me to a group with other kids who were taking the medicines like me. It was easier to remember after that. I knew if I could remember to take the medicines, I would be well. It was when I forgot them that I would be sick. But I really feel stressed at school. I want to forget that I have this disease. Some of the other kids still call me names. It helps when we have time to talk together in the groups at clinic. It helps me to remember I am not the only one, but it is so hard to accept this disease. I think Peter's story captures for us some of the critical challenges that adolescents face in regard to ART adherence. Adolescents wrestle with the developmental tasks of establishing autonomy. They push limits, they feel invulnerable, and they place a high importance on their peers. Delays in disclosure to adolescents can hurt their adherence, as can wrestling with acceptance of their diagnosis once they have been disclosed to. And then disclosure of their HIV status to others and keeping medicines a secret can also impact their adherence. HIV-infected adolescents have higher rates of behavioral and mental disorders compared to their non-infected counterparts, including ADHD, anxiety, and depression. And depression and anxiety symptoms among adolescents living with HIV have been consistently associated with lower rates of adherence and higher rates of substance abuse and risky sexual behaviors. Social issues, of course, shape adherence and health behaviors, including the HIV-related stigma that these adolescents live with and navigating their sexual debuts. The transition from pediatric to adult care, which Caroline is going to talk more about, can have a critical impact on adolescent adherence, especially if they lose support services during that time. And in considering adolescent adherence, it may be very significant whether the adolescent is clinically fragile, as is the case for most of our perinatally infected youth at this age, or whether they're asymptomatic, as would be true for most of our behaviorally infected youth, particularly given the role that feelings of invulnerability may play in taking or not taking their medicines. Now, unfortunately, we really do not know the most effective strategies to improve adolescent adherence. There are few rigorous systematic reviews of these interventions, particularly in resource-limited settings and particularly for adolescents. But it's clear that there are no easy answers. The existing studies all point to the need for multifaceted adherence interventions that are integrated into routine healthcare systems. Now, to help you consider how you might implement and integrate these kinds of multifaceted interventions, I'm going to focus more today in my discussion on some of the key principles for adherence interventions and monitoring, more than on specific examples, because I think there's such because the evidence all points to what we do on a system level, and because we really need to think through the implementation of these things for each of our settings and how we scale them up, I think it's more helpful to think about the principles, though I will reference some studies here and there as examples. Again, if you do want to see specific examples of any of these particular types of interventions, there are more of those examples within the Dropbox document. So there are a number of categories for potential adherence interventions that may work to improve youth adherence. Interventions in the cognitive sphere are those that aim to affect ART adherence through teaching, through clarification, through instruction. These interventions might include things like media education, whether audio or video or reading materials. They could include group education, education of individual patients or caregivers. And a number of these patient-based educational interventions have been evaluated and do show some positive impacts on adolescent adherence, but the persistence of these effects over time are seldom documented. I did want to highlight, is it going to go? There we go. I did want to highlight one example of a cognitive intervention for which there's a poster here at the meeting, poster 47, because it's from one of our talented medical students, Lydia Fisher. And this was an example of an animated tool for HIV education and counseling that was developed in an iterative process with HIV-infected adolescents in Kenya. It's designed to be used on handheld tablets, and I think it's an excellent example of student work. But returning to the categories, next would be the idea of behavioral interventions. So behavioral interventions attempt to affect ART adherence through direct behavior modification. So these examples would include reminder devices, things like pill boxes, alarms, SMS reminders, other cues for remembering dose times, things like cash incentives, and even directly observed therapy. As far as the evidence goes, SMS reminders have generally been shown to increase adherence, to increase viral suppression, and to increase retention in care. But this has not been true in all settings, and there's much less evidence for adolescents. The results for directly observed therapy also have fairly mixed results, actually, and generally those are options considered less sustainable for ongoing HIV therapy. Effective interventions to improve ART adherence would be those that are involving more emotional support, and certainly these have been tried as well. These would include peer support, treatment with antidepressants, counseling, and for adults, peer support has been associated with improved adherence. Given the importance of the peer group for adolescents, we have every reason to believe that this would be true for youth as well. And mounting evidence does back effective support interventions for youth. For example, a study of group empowerment sessions among youth in Thailand resulted in improvements in their adherence based on pill counts. And a recent study that was referenced earlier today, done by Bahana and Mellons and others in South Africa, suggested that adolescents and families receiving counseling that included these tailored cartoon storylines and curriculum did have increased self-reported adherence as well. Returning to the diagram, it's also perhaps important to note, too, for the effective interventions that in the adult literature, there's a strong suggestion that these types of peer support and counseling are much more effective when they're targeted to those who are known to be non-adherent, as opposed to blanket interventions overall. Biological interventions, just to touch on those, are interventions that would improve the physical ability to take ART. For adults, these have often included attempts to provide food rations or to provide vitamins or micronutrient supplements. And for adults in sub-Saharan Africa, the positive impact of food supplementation on ART adherence has been well documented. For youth, the existing evidence suggests that food supplementation has been connected with adherence to clinic visits, although medication adherence has not been seen as well. For youth, we might also consider how pediatric-friendly formulations of ARVs might be potential adherence interventions. Whether this means thinking about formulations that are more friendly to our sometimes very small perinatally infected adolescents who still may have difficulty swallowing large pills or large quantities of pills, or thinking about the acceptability and tolerance to injectables and other novel formulations of the medicines. You can see there that moving beyond the individual level of the patient is the idea of structural interventions or interventions at the care system level. We may be able to best impact ART adherence through changes in our delivery structures or additional services. And examples of these types of interventions would include things like delivering ART in community centers, community mobilization, or things like what are often called adherence clubs, but which are in fact usually an easy access care model that are used for a particular group of patients. There are good studies in sub-Saharan Africa supporting these easy access care models for adults, but it's unclear how best to select patients to include in those, and whether they would work as well for youth remains to be seen. Certainly for youth, consideration of the transitions in care among adolescents and how those care structures could support ART adherence and related challenges is an area that merits more inquiry. And then there's the idea of the combination. So the combined evidence on adherence to medication therapy across different diseases suggests that the most effective are those that are multidimensional, as we said, that use a combination of these different categories. And as we consider how to meet this critical challenge of improving adolescents' adherence, I would encourage us to think about how we can implement best these multidimensional interventions that are going to be integrated into our healthcare systems, so that we could actually incorporate strategies from across these categories into our systems. Now, when you consider adherence interventions, you cannot separate out the need for adherence monitoring. As they stated in these guidelines already, monitoring adherence is necessary to assess the effect of interventions and also to inform providers of the need to implement interventions. This matrix of adherence monitoring methods shows how our adherence monitoring strategies can be categorized on a scale of reliable to biased, and also from sparse sampling or data gathering to more rich sampling. And you can see where some of our common measurement methods fall on this matrix. So if you start here on the bottom right, certainly our self-reporting methods are significantly biased towards the positive reports. Certainly self-reported non-adherence non-adherence has a high predictive value, but it rarely happens. With questionnaires, some success has been had with well-structured and well-administered questionnaires, but adapting and validating these questionnaires for youth, and especially our youth in resource-limited settings, remains an important challenge. In the global IDEA cohort, we're currently attempting to validate a short adherence measurement questionnaire for children that was validated in East Africa in settings caring for children and adolescents there. And now we're looking at across our regions in Asia Pacific, Southern Africa, and Eastern African regions. Pill counts fall a little bit more on this side. They're generally considered a fairly sparse method of monitoring, and they can also be quite susceptible to pill dumping and therefore biased, in addition to having fairly significant personnel requirements. Pharmacy refill data is potentially more reliable and has been validated as a measure of adherence for adults primarily, but pharmacy data are often not available to clinicians. Therapeutic drug monitoring can be quite precise, but it's less often associated with our clinical outcomes, and it does not necessarily reflect data beyond the level of the drug in the patient's system. And over here on the right, you have smart monitoring devices or electronic monitoring devices, which provide fairly accurate and detailed dosing histories and potentially offer both monitoring and adherence interventions. Because of these potentials, I'm going to talk about them a little bit further. Electronic dose monitoring typically uses a technology to record the exact timing of the medication container opening, whether it's for a bottle or a pill box. These are two examples here of two of the most common electronic dose monitors that are in use, largely for research purposes. The one on the top here is a Wise Pill device, which relies on a pillbox-based design, and it records when the box is opened electronically. The Wise Pill device actually sends these data in real time to selected individuals who are usually members of the study team or a clinician. The one challenge is because of the structure, it does not work necessarily for younger children because liquid medicines cannot be used in it. This is a medication event monitor, or MEMS cap down here, which are caps that are placed on specific bottles that record an electronic date and timestamp whenever the bottle is opened. They use an integrated data software as well that allows for an automated analysis and feedback when that cap is downloaded into the information. Now, electronic dose monitoring creates a unique feedback opportunity because the patient's pattern of behavior around medication taking can actually be observed and discussed, potentially before you have virologic failure, before you have clinical outcomes that are deteriorating. You might be able to see if there are certain doses they're always taking late or interruptions on weekends and so on. This picture shows how the MEMS caps work. The data are stored in the cap that comes off from the bottle here. They're downloaded onto a computer in the clinic via simple reader, and then the software puts these data into a database that can be represented graphically in different forms. So in these displays, the time of each bottle opening is on the y-axis, and the time of the date, is on the x-axis. So you have a dot for each bottle opening. So here, the top line represents the evening doses, and the bottom line is the morning doses. And for a patient with almost perfect adherence like this one, all these dots form a solid line. Now, for patients with non-adherence, you can see that there are gaps between the dots, or how the times of day move around, so you have a lot more variability in terms of when medications are being taken. Two recent systematic reviews evaluated the evidence for electronic dose monitoring to impact medication adherence across a variety of therapies and diseases that included HIV, but were not limited to that. And while both of the reviews highlighted that the studies were quite heterogeneous, they did find that electronic dose monitoring was generally associated with significant improvements in patient adherence. And although few of these studies involve children or are done in resource-limited settings, the adherence does improve improve most when you have electronic dose monitoring feedback incorporated into your routine care, and then you use that feedback to facilitate patient education and counseling. And I think this points to the kind of combined intervention strategy that might have the most impact on adherence for our difficult adolescent patients. In sub-Saharan Africa, there have been proofs shown that this is a feasible way to address adherence among adults in terms of a combination of event monitoring and then targeted counseling. So I think evaluating these strategies among youth is something we really want to consider. Now, I work with the AMPATH program in Western Kenya. We currently have more than 44,000 children enrolled in care and 19,000 on ART at 60 clinical sites. So when we consider these challenges of what it means to have adherence supported among our patients, we're really trying to figure out what this means for the long term for a very large number of children. And that, I think, is why I especially emphasize what it takes on a systems level to try to implement these kind of changes. In our pilot work among HIV-infected children in Kenya using MEMS systems, we find suggestions that the devices significantly improve their adherence to ART. The MEMS data demonstrated relatively high levels of pediatric adherence overall, but adherence significantly improved after the first month when the MEMS data was downloaded and viewed by the participants. So the work really suggests that some combination of having the data but then interacting with the study team around those data improves adherence. Electronic dose monitoring as a monitoring and intervention strategy may offer us then a way to impact adherence from both the behavioral and cognitive levels, as well as potentially to address the developmental or social or structural issues that are impacting adherence, because we can start to get beyond the concept of just how many doses did you take. And the results from our study in Kenya demonstrate why this is important, because although we had high levels of adherence overall, we did see potentially problematic patterns. Almost half of the children experienced treatment interruptions of greater than 48 hours during the study period. And so this helps us to address some of those potential problems. In addition, it might help us to move beyond some of our challenges with our biased self-reports and biased caregiver reports. In our comparison, the MEMS adherence was significantly lower than either child or caregiver reports of the doses taken. So in that way, it shows us more non-adherence. And you can potentially combine the electronic dose timing information with established data about pharmacokinetics parameters to better quantify how the actual ARV exposure compares to what you would be intended. I have a poster up, number 25, if you want to see more about this. But this might be especially relevant for our clinical trials where we really require more accurate and detailed levels of information about drug exposure. Now, for adults, providing patients with feedback about their own adherence patterns makes more of a difference in behavior than any other adherence intervention. So again, this is why I raise this so strongly. I wanted to conclude just by highlighting a few additional adherence interventions that have a potential for impact. Certain SMS and other reminder monitor devices have evidence supporting their use. For SMS reminders, weekly reminders seem to have a more positive impact than daily reminders. We also did a lot of talking about point-of-care viral loads, so let me just talk about that for one quick moment. Certainly, this might be a really wonderful strategy for us in a way, but even if we are to have this promised dream of a point-of-care viral load, there still are some unique advantages to the idea of electronic dose monitoring timing. It gives us a marker of medication taking behavior. It helps us to enter into this broader sphere of health behavior. We can interact with patients about specific challenges, and it might actually promote more dialogue and case management than you would have just from the viral load marker. I won't go into the detail of this, but essentially you can think about how a risk of virologic failure might be able to be predicted if you are able to provide this combination of information about their clinical and MEMS data in real time and to allow providers to act on that. In summary, what we really need is the right information at the right time to help us direct the right set of interventions. As Kaplan and colleagues say, if we have this idea of a red alert, if you really know who you need to target your resources for, you can really focus your interventions on those patients who are having the biggest challenges. And in those cases, studies find great suppression of virologic breakthrough. So in summary, what do we want? We want things that are low patient burden, that are affordable, reusable, supply chain friendly, work for a wide range of dosing regimens, allow for a comprehensive response, and most of all, that they work for adolescents. This is who I want the interventions to work for. These are our adolescents in Kenya, with whom I work, pictures just from a week ago, and they really are my heroes. I think that in the face of the most challenging stories, they are showing us what possibilities lie ahead. So I want us to find interventions that can help them. Thanks.